Hello everyone. So today we'll be talking about a very important topic in fixed prosthodontics, which is your abutments in FPD. So the abutments is one crucial component of the FPD. So it can be compared to the supporting structure or the supporting pillars which hold your FPD. So whatever stresses is acting on your FPD is transmitted through the abutments to the ridge and the bone. So when a patient comes to you with missing teeth, you inform the patient that there might be supraeruption of the opposing tooth, there will be mesial drifting of the adjacent tooth. The options which you provide for the patient, one of which will be your removable partial denture, and then even your fixed partial denture, and the last but not the least, but your implant supported prosthesis. Okay, so how do you decide if the patient is a good candidate for your fixed partial denture? That is the topic which we'll be dwelling into today. So what is an FPD? An FPD is a prosthesis which replaces a missing tooth by taking the support of the adjacent natural teeth present. It is a fixed prosthesis which cannot be removed by the patient. So whatever forces is acting on the FPD or the bridge, so it can be compared to a bridge deck wherein the stresses of flexion is transferred to the abutment or the supporting pillars or struts which holds the bridge. Same way, an abutment is a supporting pillar for an FPD process. It can be a tooth, a portion of a tooth, or an implant, which will support or transfer the stresses acting along the FPD processes on its long axis. An ideal abutment will need a good crown to root ratio. I'll be discussing about this in detail in the later slides. A good thickness of enamel and dental. The structure should be adequate enough to be prepared for an FPD. Good bone support, which will hold the abutment teeth. There should not be any vertical or horizontal bone loss, and at least 2 mm of thick keratinized gingiva. So this is an ideal abutment, which is not the clinical scenarios which we face on a daily basis. So there are abutments which is defective in size, shape, or number. So if the structure of the abutment teeth is affected, it is mainly due to developmental defects in the structure, which is amelogenesis or dentinogenesis imperfecta, fluorosis or hypercalcification, internal resorption, etc. Now, other defects include your environmental, that is caries, trauma, or if the teeth is tilted due to after the extraction due to drifting or supraeruption, if the teeth is abraded or attreated due to parafunctional habits or erosion. Other defects include your skeletal discrepancies wherein your teeth is proclined due to a class 2 skeletal jaw relationship or a class 3 jaw relationship, or the teeth is defective in number. Okay, or the teeth is placed in a crisscross, there is severe crowding in the teeth which does not serve it as an ideal abutment. Now you have your ideal and questionable abutments. How do you choose which is the right abutment for your FPD? For this, we assess the diagnostic cast of the patient, which we obtain on the first visit when the patient comes to us. So the upper and lower cast, when it is occluded, we'll get to know how the opposing tooth is, if it is supraerupting into the edentulous space, if there is enough adequate vertical space for the FPD, the axial inclination of the abutment teeth. We also take an OPG and draw a line on across the long axis of the abutment teeth, which is to be used, and converge them to form an angle. If the angle is within 25 to 30 degrees, we can confidently tell the patient that yes, an FPD processes will be possible for you. Now, the factors which influences the abutment selection in your FPD design include these. So we'll be talking about uh, each of these in detail today. So the crown length should be minimum 4 mm. So when I say the crown length, it is your clinical crown length and not your anatomical crown length. And it should be measured from the crest of the alveolar ridge to the cusp tip. The root length is from the crest of the alveolar ridge to the root tip, and an abutment teeth should have minimum 4 mm of tooth structure for it to retain the fixed processes. If it is not there, then you have to go for alternate grooves, which acts as a retentive feature. And the crown form should also be, designed in such a way that the forces acting on the abutment teeth is less. Suppose if the patient is having good cuspal morphology, tall cusp, the amount of stresses acting on the abutment teeth will be more in excessive movements. So you have to strike a balance in maintaining the aesthetics as well as the load which is acting on the abutment teeth. Now, if there is any kind of decay or if there is any bone defect, root morphology, the root concavity, any kind of root caries present, you need to assess this. And in case if there is root caries, you need to inform the patient that even though we are using it as a primary abutment, it might fracture in the future and it is better to extract it rather than use it as an abutment. Also, if after removing the decayed or the defective tooth structure, if there is only 2 mm of tooth structure which is remaining, either consider doing a post and core and crown lengthening and then give the FPD prosthesis, and also inform the patient post and core is also a post and core treated abutment is also compromised, and it might not serve as a good abutment to transmit the stresses along it, because there is always a chance of vertical root fracture. Now, how do you assess if the abutment is, optimum enough? Based on the type of tooth loss which is present, you measure the thickness of the wall of the abutment teeth as well as the height of the abutment teeth. Now, if the thickness to height ratio is more than 1 mm, you can give an FPD prosthesis by giving additional features like boxes, grooves, pinholes, vertical walls, etc. But if it is less than 1:2, then you should consider giving a post and core and then a crown, and make sure there is a ferrule of 2 mm of tooth structure which is present by crown lengthening in that particular tooth. Now, in a FPD prosthesis, the stresses acting on it is mostly mesodistal, whereas in a single crown, it is faciolingual. So you need to consider, reducing the torque or the leverage which is acting on the FPD by giving a facial or a lingual groove depending on where there is adequate thickness of tooth structure present. In case if there is total loss of supragingival tooth structure like this, either consider giving a pin retained amalgam core restoration and then a crown, but definitely post and core is an option which you need to tell the patient. Now, the next option is your crown root ratio. So a patient should have optimum crown root ratio of 2:3 to be considered for your FPD prosthesis. Now, if this is not there in a clinical scenario, if it is periodontal, if there is recession, etc., you need to at least have a 1:1 crown to root ratio. The crown to root ratio can definitely be altered by your orthodontic extrusion or crown lengthening. Now, there are some exceptions to this 1:1 rule. If the FPD is opposed by natural teeth, yes, you need to consider the 1:1 ratio. But if it is opposed by either periodontally weakened teeth, or if the opposing dentition is an RPD, the forces acting on the FPD is much, much lesser. And in such cases, you can consider giving an abutment teeth which does not have a 1:1 crown root ratio. If that is not the case, if it is opposed by a natural teeth or FPD, consider taking additional abutments for splinting and then give the prosthesis. Now, coming to Ante's law, which is the most crucial criteria for selecting a abutment teeth. Ante's law states that the teeth, the root surface area of the teeth which you are replacing should be equal to or lesser than the sum of the root surface area of the abutment teeth from which it is taking support of. So Ante's law stated that you should never ever replace a missing tooth with an FPD if the root surface area of the abutment teeth is not greater, the sum of the root surface area is not greater or at least equal to the root surface area of the abutment teeth which it is missing. So Ante's law mainly intended to preserve what was remaining rather than giving a long span FPD and replacing the patient's dentition. Now, how do we know that the root surface area of an abutment teeth is good enough for the patient? So, for example, if we take our canine teeth, a canine teeth will use a lateral incisor and the first premolar as its abutment teeth. So, the root surface area of the canine teeth which is replaced should be equal to or lesser than the sum of the root surface area of your lateral incisor and your first premolar. Now, this is not the case if the teeth is tilted, if it is drifted, or if there is any alignment issue, or if there is any kind of gingival recession wherein there is loss of bone support. So in such situations, you need to consider alternate abutments, using secondary abutments or using a double abutment. Okay. Now moving on to the, if you are consider giving a long span FPD, always understand that the more the number of pontics you are replacing, the worse the prognosis will be, the more the leverage and torque is going to be. But yes, the FPDs don't fail because of overloading on the abutment teeth. It mainly fails due to biomechanical factors of material fractures or improper occlusal scheme planning, etc. Now, if in case if you're trying to splint it to a secondary abutment or a double abutment, you need to make sure that the secondary abutment which you're using has a good crown to root ratio, a good root surface area, and also the space between your primary and your secondary abutment should be there in such a way that it does not impinge onto the gingiva when the patient is using the FPD, because there is always flexure and the primary abutment will tend to act as your fulcrum point. Okay, so the patient should be healthy enough to maintain it. So this is only given in a case scenario wherein your FPD process is not going to be retentive using your primary abutment, or the primary abutment might go for a toss in the future. Okay. Now coming to the periodontal health, so yes, 1:1 is the minimum crown root ratio which we require. Now, in case if the abutment teeth are not periodontally healthy, you need to consider if it is grade 1 mobile, yes, you can try splitting it to the adjacent teeth using additional abutments, but make sure that the opposing occlusal forces which is acting is minimal, or keep it out of occlusion. In grade 2 mobility, it is contraindicated. Now, in cases wherein there is periodontally compromised molars with furcation involvement, you can try going for a bicuspidization, wherein you split the crown into two and give two small premolar crowns, so that the patient can maintain the area, that is the furcation area which is involved for the molar, and at the same time use it as a crown. Okay. So the root configuration or the root morphology also affects your treatment plan. So long, slender roots tend to have lesser root surface area compared to your broad, thick labiolingual section of the roots. So this is the diagram which depicts the same. So the root surface area is more in your circular cross section rather than your elliptical cross section. Also, you have to understand that divergence will increase the root surface area compared to your fused roots. Now the span length. Now a longer span of FPD, if you're planning for that in a patient, you have to understand that for each pontic you're replacing, the amount of flexion on that FPD is increased by 3 times. If the vertical space is high for replacing the pontic height, the occlusive gingival height of the pontic, if you're increasing the pontic height by 1 time, the flexion or the flexion of the FPD will be reduced by 3 times. So let's see that in the next slide. So here they have given the thickness as T. If it is reduced by half, the flexion of the pontic is increased by 8 times. Whereas the pontic span, that is the length of the span, if it is increased, so if they here the number of pontic is increased to 3. If it is increased to 3p, the flexion is increased to 27 times. Okay. So if you are planning for a fixed long span fixed partial denture, try considering giving a high yield strength material like nickel chromium. Also try to increase the occlusive gingival dimension of the pontic which you are replacing, so that the flexion is minimized. Okay. So next is the main criteria for selecting your abutment teeth, which is your axial alignment. So most cases, the patients come to us after 1 or 2 years of extraction. So what happens that the molar tends to tilt mesially, because our teeth have a tendency to drift mesially. Now the angle formed between the long axis of your molar and your premolar should converge to be within 25 degrees, as it is shown here in the diagram. So this you can see or find out from your OPG. Now, what happens if you give an FPD in this situation is you tend to over-prepare the molar teeth, and also the forces distributed will be on the mesial bone and not along the long axis of the tooth. Also, you might end up slicing the proximal half of the adjacent natural teeth, which is healthy. Now, you might also consider giving resin bonded bridges, but resin bonded bridges are temporary, and it is only indicated when the axial inclination of the abutment is within 15 degrees. Other options which you can consider giving the patient is your proximal half crown. So instead of giving a full coverage retainer, you're giving a 3/4 crown, leaving the distal part of the tooth intact. So this is only given if the distal half does not have any caries, not decalcified, and the patient can keep it clean. Another option is your ortho treatment. You orthodontically upright the tooth. Now this is a more ideal option. This will take about 3 months, but the advantage is there is no mesial bony defect which you can expect compared to all the other options. So whatever forces are transmitted is transmitted along the long axis of the tooth. Now, if the patient is having buccal or lingual amalgam restorations, which makes the teeth already, fragile, you cannot give a partial coverage retainer there. You have to go for a primary coping, which changes the path of insertion, for the secondary coping, which is inside the FPD prosthesis. So this whole unit is called as a telescopic prosthesis, wherein the primary coping will change the path of insertion for inserting your FPD, making it straight. Now, in case if the patient's molar is not only tilted mesially, it is also tilted buccally or lingually too much, excessively. And if you want to give this, you end up preparing it too much. So the over preparation might tend to compromise the retention of the FPD. So to avoid that, you can go for something called as a non-rigid connector, wherein you maintain the tilt of the abutment teeth. You don't have to over prepare it. but at the same time, you also give a key and keyway non-rigid connector on the distal half of your premolar. So this is mainly indicated if your premolar is already having a distoproximal class 2 amalgam restoration, or if the molar is severely tilted. Now, the arch form also affects our treatment plan. Depending on the tooth which we are replacing, each tooth is exhibiting different types of lateral stresses in excursive movements. So, when the patient is using the prosthesis to chew food, suppose we are replacing missing maxillary central incisors. Now, you need to take your abutment teeth, definitely your lateral and your canine. So, this is your primary fulcrum line. But the pontic which is there, it is lying outside the interabutment axis line, and this will form as your lever arm, okay, which will rotate around your fulcrum line. So to balance it, you need to take additional secondary abutments posteriorly as well, which might include your first premolar or second premolar. Now in an ovoid or V-shaped arch, because the lever arm is longer, you need to take till maybe second premolar. Whereas in your square or broad shaped arch, you can take only maybe up till the first premolar and then leave it be. So this will also affect your treatment plan because the arch curvature distributes the lateral stresses accordingly. Now, a patient, when he or she comes to you, you need to assess if the patient belongs to a canine guided occlusion or if the patient is a group function occlusal scheme. Now, depending on other factors like parafunctional habits, TFO, you can consider giving a group function occlusion. So, if you are considering giving a group function, you need to take multiple abutments for splinting because the force is distributed on multiple teeth. It's not only on one teeth. If it is a canine guided occlusion, which is definitely better, you need to make sure that the canine is healthy periodontally and it can take up the load. Okay. So the endodontic status of the tooth you have to assess when the patient comes to you of the abutment teeth. It has to be vital. You can do vitality tests. Now, the key rule here is to try to maintain the vitality as much as possible. If it is not possible in situations wherein the core of the teeth is involved, wherein whatever lesion is there, carious lesion or fracture, etc., is involving the pulp, then better to go for a root canal. In case of severe attrition also, it's better to go for a root canal. Now, partial veneer crowns are favorable as an abutment. Why? Because it will also allow in pulp testing. If the teeth has been pulp capped, indirect or direct in the past, definitely go for a root canal and then go for your FPD prosthesis. Now, the endodontically treated teeth tends to fracture, so that is why it is not favorable. Now, teeth are not the only ones which take up the load. The ridges do as well. So thin and severely resorbed ridges take up lesser load compared to your wide flat ridges. The age of the patient also is a determining factor. Young patients will tend to have high pulp horns. So if you are trying to do a vital tooth prep, the pulp horns are most likely to get exposed. So it's better to suggest such patients resin bonded bridges than going for a conventional FPD. In elderly patients, you have good amount of sclerotic dentin, good candidates for vital tooth prep. But yes, again, attrition, parafunctional habits is also another factor to consider. The patient's speech should not be affected, especially when you're replacing your FPD with anterior teeth, because the labiodental sounds, F and V sounds, etc., get affected. Now, if you are considering giving a long span prosthesis, what and all you can expect? You have to explain the patient that the connectors might break, the ceramic might fracture, and also explain to the patient that if the abutment health is already compromised, definitely there is a chance that the FPD also might not last long, and there might be secondary caries or there might be periodontal issues in the future. So in such cases, how do you minimize it? You can try giving a double abutment as shown here. Also make sure that the pontic and the connector is of optimum strength and bulk, and the material which is used is strong enough. But make sure when you are giving such double abutments, there is good amount of space for the patient to clean using a interdental brush or a super floss or a bridge floss, etc. Now, the aesthetics wise, if you consider, so if you're replacing maxillary 6-unit anteriors, the connector height looks very, very artificial, especially if the patient is having a midline diastema earlier. So in order to avoid that, in order to create that natural effect, you can go for something like a spring cantilever FPD or a loop connector FPD. So this is a spring cantilever or a loop connector, which does not show the metal through and also maintains a natural look for the patient. So you also need to assess if the patient is having any kind of bruxism or any kind of parafunctional habits. So what happens is, because of the bruxism, the abutment height, you might deem that the abutment is healthy, But if the patient is grinding his or her teeth at night, the abutment health is severely compromised because it is taking up the load of the FPD as well as the additional load exerted by the patient. So you need to treat that as well before starting the FPD. Now, some special cases wherein there are edentulous span adjacent to the abutment teeth. So this is called as your pyre abutment. What do we do in such cases? Do we go for a conventional FPD? The problem here is what happens is there are torsional forces which is acting on the pyre abutment, which rotates the pyre abutment, and in the future it might go for a toss. Definitely this type of process cannot be used if the pyre abutment is mobile. So what do we do in such cases? We go for breaking the stress in the middle, separating into a mesial and distal segment using a non-rigid connector, wherein there is a key in the distal segment and a keyway in the mesial segment, which is resting on the pyre abutment. And also another option is to consider is your cantilever pontic in your FPD processes. Now, where do we place this non-rigid connector? The non-rigid connector is indicated if the opposing teeth is not missing, and also the connector should be placed on the distal half of the pyre abutment and not on the mesial half, because our teeth tend to drift mesially. So when we are chewing, the key and keyway will get seated if it is placed distally rather than mesially. Also, the anterior teeth might supraerect because of lack of contact, which might lead to, again, the unseating of your key and keyway. Okay. The cantilever abutment situation is mostly indicated in case of your missing lateral incisors, or in case of your mandibular first premolar or your maxillary first premolar. Now, here some occlusal schemes are needed, wherein the cantilever pontic should not come in contact or under load in your excursive movements. If you are considering giving a distal cantilever pontic, there is a chance that the primary and secondary abutment might fracture or go for a toss due to torsional stresses. So it is not indicated generally. Now, any FPD which replaces a missing canine is considered to be complex. In case of your maxilla, the canine tends to lie outside the interabutment access line, which will increase the torsional load acting on the abutment teeth. The FPD is more favorable in your mandible. So in case if a patient comes with a missing maxillary canine, better suggest an implant rather than an FPD prosthesis. Now, if you are considering splinting to an implant abutment, you need to consider that the vertical load, which is acting the flexion load, is 5 microns and 28 microns in your implant and your natural tooth respectively. So what happens is in the future, either the tooth will go for a toss or the implant might fail. So the bottom line here is an FPD cannot be splintered to an abutment teeth. Tooth implant supported prosthesis is not recommended. So to summarize, you need to consider the vitality status, if there is any fracture, any endodontic issues or any cavities. Post-encore, you also need to assess the bone loss, the root morphology, furcation involvement, mobility, any signs of parafunction. Now, where do we give removable partial denture? When do we decide? You can give it if there is no distal abutment to support your FPD process, or if in addition to the canine, 2 or more teeth are missing. Also, in cases of your anterior spans with more than 4 incisors replacement, or posterior spans with more than 2 teeth replacement, or multiple bilateral edentulous spaces. To summarize, you can give a conventional FPD with a 25-degree inclination in the preparation modification, good crown to root ratio, at least of 1:1, and no mobility, good root morphology, and also provided there is no issues for giving the FPD, and RPD is not indicated, especially in cases like gag reflex or muscular incoordination where the patient is not comfortable using the RPD, or in case of a tori. So in all these situations, you need to consider giving a conventional FPD, and resin bonded is indicated as a temporary option wherein the abutment teeth is within 15-degree inclination. Thank you for listening.